Well, hello, everybody. Welcome, and thanks for joining us today. To all the new heart failure fellows joining us in the group, you're very welcome, and we're excited to have you here. If you do need to jump off the meeting, just a reminder that this will be recorded, so that you will have the opportunity to watch it at a later time if you would like. And I can get that information to you if you reach out to me through email. What we're going to be doing today is we're going to be starting off with our curriculum for the year. I'm very excited to have Dr. Paul Heerdt joining us. Dr. Heerdt is a professor of medicine, or a professor of anesthesiology, I should say, here at the Yale School of Medicine. He's the director of the Anesthesiology Applied Hemodynamics program, and is going to talk to us about the hemodynamics and physiology of heart failure. So, Dr. Heerdt, thanks again for taking the time, and look forward to hearing what you have to share with us.
Thank you very much. I appreciate the opportunity. I'm actually going to start by turning my camera off because otherwise it will freeze and leave an embarrassing picture of me on the screen. Let's just start off here a little bit. Just a few disclosures that I have to put out here for some consulting and some funding for source data that I might show. More importantly, though, I'm not an engineer. As was mentioned, my clinical trainings in cardiac anesthesiology and critical care medicine. My research training is in cardiovascular pharmacology. I actually did my graduate work in a cardiac dynamics lab with a couple of the people that developed dobutamine. So I've been hanging around the kind of pressure volume ventricular function world for a long time. Now, the other thing is over the past 30 some years, I spent a lot of time, maybe too much, looking at waveforms. So we'll spend a good bit of time talking about acquiring and interpreting waveforms for pressure and volume. But I'm not the only one that spent a little bit of time looking at waveforms. Otto Frank actually constructed ventricular pressure volume relationships in the late 1890s using isolated frog hearts. He actually first plotted volume as a function of pressure, and it wasn't until his work was translated later from German into English that others rearranged it into our common representation of pressure as a function of volume. Frank also made some interesting observations about isometric or isovolumetric pressure waveforms. And we're going to be touching on these again because they're just as important today as they were when he described them well over 100 years ago. So the outline here, we're just going to spend time on concepts of source signals, assessment of function morphology, and then I'm going to try to put this into a context of theory versus practice in terms of the source signals, assessment of function morphology. Because in the real world, things don't necessarily always work as they're presented to us in textbooks. And if we have time, we'll jump into alternatives for different ways of approaching pressure volume analysis. And I'll end up maybe we'll talk a little bit of wizardry. I was reminded to ask all of you to check for your email for survey information. So a few little questions here. True or false, pressure volume analysis is primarily a laboratory tool. Acute variation in load is required for optimal analysis. The same analytic techniques are always applicable to both the left and right ventricle loops. Loop morphology can be a very important variable. And full pressure volume loops are required for generation of meaningful information. And we'll touch on all of these topics as we go through. Well, let's put the first one to bed initially. There is now a system approved for clinical use for ventricular pressure volume analysis. This is out there, and a lot in the literature for describing catheter-based interventions, heart failure, CRT, surgical reconstruction, and mechanical circulatory support. As a recent paper even described even more for the right ventricle, similar applications. And I think what you'll find is there's going to be more and more published on the right side because it is far more accessible than the left. Let's start with source data. The most common one that is certainly reported in the literature are what I call direct synchronized measurements of pressure and volume, where the volume is measured by conductance, which I'll talk about momentarily, and the pressure of micromanometry, or where the transducer is located directly on the catheter and then transmitted electronically back to the acquisition system. So you're avoiding all the distortions associated with a fluid-filled system and tubing. The green shows a volume trace. The blue shows a pressure trace. These are from the right ventricle. And when you put them together, they're sampled at exactly the same time and the same rate. You can generate these nice clean loops. For those of you that have not used conductance, I presume many of you probably have. It's a the commercially available one for clinical use has a pressure interface, a volume interface that goes to a box, and what I call the business end. The business end, this is a 7 French catheter. The business end has 12 electrodes and the pressure sensor right here. I sent out this recent review about applications for left-sided pressure volume analysis. And the general gist for conductance, and I'm certainly, as I said, not an engineer nor a physicist, but the idea is the outside electrodes provide a low voltage, high frequency current, and these inner electrodes then sense the change in this current or the reduction in this current as it crosses between the electrodes, or this is the conductance of the electricity of the voltage. Each one of these segments, then, the change in the voltage as it goes across is proportional to the volume in between. So what you end up is a series of segmental volumes. And since you have pressure simultaneously, you can generate a segmental pressure dimension relationship that are shown here between the individual segments. What you're able to get on the display usually is the fact that some of these may be distorted. So for example, this is segment 7, which is up here just to the aortic valve, and you can see it's distorted. So what the system would allow you to do is to pick the segments where you think the morphology is correct. You then add the volumes of these individual segments together like you would for Simpson's rule to derive a total volume. This recent paper describes the same application in the right side. And interestingly enough, if you look, the morphology of these individual segments they show are virtually identical, which is actually not true, as you folks know, probably even better than I do. Unlike the elongated ellipse of the LV, the RV is a crescent wrapped around the septum with a completely different characteristic of its contraction dynamics. Another source of flow signals that you'll often see or sometimes see in the literature is the volume signal, is to use flow as a surrogate. And here's how that works. So if we have the outflow in milliliters per second from the pulmonary artery or the aorta, think of this as the reciprocal of the change in volume. Volume goes down as the flow in the outflow goes up. This is in milliliters per second. If I integrate the area under the curve and I turned it into milliliters per beat, and I flip it over, it becomes directly superimposable on the ventricular volume trace. And there are reports in the literature where this methodology has been used to construct the upper portion or the systolic portion of a pressure volume loop. Now we're seeing more and more the idea of using different imaging techniques. So what I call imaging that is unsynchronized, meaning it is not acquired at the same rate as the pressure, or the sampling rate is not the same. And in fact, some of these may be the acquisition of pressure and volume may be hours or even days apart that you find. Most commonly now we're finding in the literature is 3D echocardiography, and it is possible to take your 3D echo volume signal and adjust the sampling rate so that it directly relates to a full volume signal that's acquired simultaneously with pressure. You've all seen this before, the standard morphology, the idealized pressure-volume relationship, where you get initial filling in diastole with minimal change in pressure. Contraction then begins. You have isovolumic contraction till the aortic or the pulmonic valve opens. You then get the ejection phase. The ejection phase, once the pressure in the ventricle falls below the outflow pressure, the valve closes, and you get the isovolumic relaxation phase, and then the whole cycle starts again. An important consideration in this idealized representation is that end ejection and end systole are regarded as the same. So at the end of ejection and end of end systole, you begin the isovolumic relaxation period. And at this point, end systolic pressure would be at this same place. Now, all textbooks nowadays tend to have a representation of what we call the reference standard for ventricular function, or the multi-beat pressure volume relationship. And the principle of this is We then create a series of loops over changing preload, or cable occlusion is a common use for this. We take the upper left-hand corner, what we're calling end systole, we regress this to define the end systolic pressure-volume relationship, and also the volume intercept, which is commonly called V0, and this represents the theoretical volume that would be present when the end diastolic pressure is 0. Keep this principle in mind because we're going to come back to it. The slope of this line then represents end systolic elastance, which is regarded as a reference standard for contractility. If I take a point here in end diastole and I look at the change in my end diastolic pressure up to my end systolic pressure, I can then look at the slope of this relationship and use it as a summary metric for afterload. It's simply the end systolic pressure divided by the measured stroke volume for the first beat. And we call this is often regarded with some limitations as a lumped parameter for afterload because it incorporates resistive, elastic, and reflective components. We can then look at the ratio of contractility to afterload as a coupling metric, or EESEA, which you'll commonly see in the literature now as a way to express ventricular vascular coupling. Ideally, this afterload metric stays the same from the first to the last beat, and this is not necessarily true in the real world. We can regress the end diastolic pressure-volume relationship to create a nonlinear slope. There's several equations that have been expressed in the literature for describing this relationship, but all of them include an alpha component, which is essentially giving an idea of what the V0 for the end diastolic pressure-volume relationship is, and at what's known as a beta stiffness constant. Now, me, and I think many other people have a hard time interpreting a nonlinear beta stiffness constant. So an alternative approach has been described in which the relationship, this nonlinear relationship, is solved for an estimate of what the volume would be at an end diastolic pressure theoretically or 30, or you'll also find in the literature 20 or 15 millimeters of mercury. And what you end up with then is a discrete number in milliliters. This is regarded as a capacitance metric. It also helps describe the end diastolic pressure-volume relationship and tends to be a little bit more easy to understand, again, as a single metric that's expressed in milliliters. So the idealized relationship we find all over in our textbooks is from the pressure-volume relationship, we can describe contractility as end systolic elastance. We can generate metrics of diastology. We can come up with an estimate of total afterload. We can then look at the relationship of contractility and afterload as a coupling metric. We can take the area of the initial loop here as stroke work. If we look at the relationship of an area that's defined by the end systolic pressure volume relation, the end diastolic pressure volume relation, and the actual loop, it defines the potential energy that's stored in the walls of the ventricle. If we add this potential energy in the stroke work, we come up with the pressure volume area, which is regarded as a correlate of oxygen consumption. And if we then look at the stroke work as a function of the pressure volume area, this is commonly used to express efficiency. So here we have a way of looking at systolic function, diastolic function, and mechanoenergetics. Now, let's go on and look at some of these in the real world. And I will say in the real world, sometimes it works quite well. This is an example from an experimental study of the response to dobutamine. And you can see the end systolic ventricular elastance or contractility goes up substantially from one to the other. The beta stiffness constant for diastolic function actually changes very little in this. Keep in mind, though, that what you see is not only a change in the end systolic pressure-volume relationship slope, there's a shift in this V0 value. Again, I'll get back to this as an important component to consider when you're reading the literature. Less well appreciated is another approach to contractility called preload recruitable stroke work, which essentially takes the area of an individual loop and plots it as a function of its end diastolic volume or its preload. So you're able to generate a slope, and here it is at baseline, and here's what happened to it with dobutamine. Now, I plotted them both on the same scale, but if we are on different scales, we plot them on the same scale. Here's what you see is the slope of the dobutamine here and the slope at baseline here. And you recognize this largely as a linearization of the Frank-Starling mechanism, where the Frank-Starling mechanism will define contractility as more or less stroke work at any given end diastolic volume. Now, I mentioned this V0, and when you get in the literature, this comes out to be one of these sort of inconvenient truths, as we will, that a lot of times you'll find that you end up with a negative value. And obviously, it's impossible to have a negative end diastolic and a negative volume here. So the question is whether this is a technical issue, whether it's an analytic issue, or whether, as you find somewhere in the literature, it's suggested that the end systolic pressure-volume relationship is in fact nonlinear, as shown here. These are considerable discussion, will take considerable discussion. It's well beyond the scope of what we're going to be talking about today, but I wanted to plant the seed that you will often see V0 as a negative value, and more commonly when loops are presented in the literature, they actually ignore presentation of V0 altogether. Morphology is important. This is an example of a normal PV loop. This is in the setting of significant MR. You can see with the initial contraction, the incompetent mitral valve allows regurgitant flow, so there's no isovolumic relaxation. You end up with a very high left atrial pressure, which quickly exceeds the left ventricular pressure during diastole, so there's a very short, if any, end isovolumic relaxation period. You'll see a similar pattern with aortic insufficiency, and here there's no isovolumic contraction. And since the aortic pressure very rapidly exceeds the ventricular pressure at the end of ejection, you will see very little isovolumic relaxation at all. Now, with more common access to conductance catheters in the clinical world, we're seeing some interesting reports, for example, of what happens with structural heart interventions. This compares, for example, end-to-end repair with an application of a mitral clip in the setting of severe MR, where in black here you see the native, the original baseline loop, and what happens after the clip is applied, where you start to see some resumption of an isovolumic and an iso contraction and relaxation. Alternatively, in the setting of aortic stenosis with a TAVR, you'll see a reduction in pressure, an improvement in ejection, a larger ejection fraction. Importantly, though, for both of these interventions, they occur along the same end diastolic pressure-volume relationship. So we're changing systolic characteristics, not diastolic characteristics. Now, it's important. This is a report showing you actually don't need conductance to show the same thing. This is a mitral clip application. This is left atrial pressure from a transeptal puncture. You can see it's hitting V waves of over 50 millimeters of mercury. Here the clip goes on and there's normalization of the left atrial pressure. Under this setting, adequate 3D images were required before and after clip application to actually generate pressure volume loops that show the same thing that has been reported using conductance catheters. In the literature now, we will see many idealized things. So from the setting in heart failure with reduced ejection fraction, the common representation is that there's a shift, a higher volume, a shift, the end diastolic pressure volume relationship stays the same, but there's a shift of the loop along this ED-PVR, but a change in the end systolic pressure volume relationship or contractility. Alternatively, in the setting of HFpEF, we find that theoretically, and you folks probably know better than I do that this is a point of debate as to whether or not contractility changes with HFpEF. But ideally, there's no change in the end systolic pressure volume relationship, but a change in the end diastolic pressure volume relationship such that there's a higher pressure at a lower volume. This review was done in mice, which is why the volumes are shown in microliters, but the concepts are the same for humans. I want to point out, too, when you look in the literature, that nothing happens in a vacuum. And here's the example. This is one that's showing the transition from an acute heart failure with reduced ejection fraction to chronic, where in acute setting, you stay along the same end diastolic pressure volume relationship. But with chronic failure, you end up with thinning and dilation of the walls. So there's the shift to the new ED-PVR. Well, this is nice conceptually, but as you folks well know, in the setting of chronic dilated heart failure with reduced ejection fraction, there is most likely some degree of functional mitral regurgitation. So this idealized loop is probably not the way it's actually going to look in the real world. This busy slide emphasizes this somewhat further because, again, you've got two pumps in the same sac with valves, and they are interdependent. And the most common cause of RV dysfunction or RV failure most likely is LV dysfunction. And the most common cause of pulmonary hypertension is obviously left heart disease. And the representation here, I won't go through each of these, is showing how the pressure-volume relationships for both the left and the right ventricles shift as you go from isolated LV failure to biventricular failure with and without changes in pulmonary vascular resistance. The point is that we're not dealing with a nice, discrete, well-defined individual loop that shifts in an entirely predictable way. You're dealing with shifts on both the left and the right side of the heart, and these shifts can be interdependent. And as I'll show you momentarily, even this idealized baseline normal RV pressure volume loop is not the way it necessarily is going to look in the real world. One of the things I want to point out too is what source data you use for describing the PV relationships. So again, this goes back to a study we've been doing where we're using conductance, volume shown in green, and 3D echo shown in red. And while we can create them, the resulting loops don't actually represent the same thing. The conductance shows this late drop, which is shown in the loop. I don't know if this is real or artifactual, but it would look to me as it's an artifactual change. But more importantly, we look at the isovolumic intervals, and it looks like for the loop generated using echo, there's tricuspid regurgitation with loss of isovolumic contraction, and this is not present in the conductance. So which of these is true, I don't know, although I can tell you the echo exam in this patient showed only trace tricuspid regurgitation. The other thing that comes out when we consider biventricular is that while the idealized LV loop looks like this, and we get this nice point where end systole and end ejection are the same, the normal RV loop does not. It tends to be triangular, not rectangular. And this creates an interesting problem for defining end systole versus end ejection. And in many circumstances, ejection progresses from the right ventricle for an extended period of time, making it very difficult to define an isovolumic relaxation period. In fact, a study was published many years ago suggesting that under normal low impedance conditions where ejection from the RV continues for an extended period, there's actually no isovolumic relaxation in the normal right ventricle. This gets to then how we define end systole in our pressure volume relationships, and coming up with something that's applicable to both the left and the right ventricle. And the most common thing using PV relationships is to take your pressure waveform and your volume waveform, divide the pressure by the volume, which gives you a continuous elastance curve shown in brown. And the point at this peak elastance would be what we call end systole. Now, this is a study that showed a way of coming up with a timing marker to define it, but it demonstrates again that you can generate a timing marker that shows that will represent where end systole occurs based on the ratio of pressure and volume. But it isn't necessarily, this shows the timing of the end systolic point and end ejection, where the two are not necessarily coincident. For the RV, this becomes a big deal because the morphology of the RV pressure waveform changes under different conditions from what's known as an early load where the highest pressure is early in systole to late load with vasoconstricted states where now the highest pressure is late in systole, as commonly you'll see for the left ventricle. And this is indicated in their pressure volume relationships where the point of end systole shifts along this curve. But importantly, the definition of end systole when you use the ratio of pressure and volume stays constant and is the same for both the right and the left ventricles. I also then will note the importance of morphology here. This is a recent report comparing different morphologies of the right side PV loops. Again, the right's becoming more common because of easy access. And this shows the characterization of these, what they call typical patterns. But I want to show something that again underscores when you look at the literature, so look at this with a critical eye. Here they represent that the volume actually becomes negative, which is obviously not true, but those were the data that were presented. And in this one, it indicates that during the entire diastolic filling pattern, the pressure declines, which again is not physiologically true. So this again uses an example of how we need to interpret these loops in the context of how they're measured and the potential limitation of the technology used. So to sum up this portion of it here, we need to think that differences in theory and practice for the clinical use of pressure volume analysis, because continuous simultaneous measurement of pressure and volume is rare. And in fact, preload variation for creating our reference standards using continuous simultaneous measurement of pressure and volume is even rarer. In the real world, the loops seldom look like those shown in the textbooks, and that methods developed for assessment of LV function are not necessarily directly applicable to the right. They often require some sort of manipulation. And just for the last couple of minutes here, I wanted to talk about how we're moving away, or the opportunity to take what's known as single beat measurements without having to create total pressure volume loops. And this is the most common one that has been used. We theoretically assume in our standard analysis that there is a reduction in preload, and we create this end-systolic pressure-volume relationship along a preload reduction. Well, theoretically, if we took it in the opposite direction and we narrowed the outflow tract to the point where eventually, narrowing the PA or the aorta, eventually we have a loop, a beat that's isovolumic. This model says, well, if I know the end systolic pressure, and I know what we call this P max, the maximal pressure that would have been attained if the beat remained isovolumic, I can calculate end systolic elastance or contractility as the P max minus the end systolic pressure minus the stroke volume that was measured through some other way without actually having any knowledge of loops at all. And I can use the same methodology we use for a full loop set for calculating arterial elastance as a metric of afterload as end systolic pressure divided by stroke volume. The key here is how we come up with this P max. And there are a couple really nice things going back into the 80s describing what they called hydromotive source pressure, where if I take a segment of the pressure rise or the isovolumic pressure rise, and I fit it to a curve with the isovolumic pressure decline, what I'm going to find is the ability to predict what the maximal pressure would have been if ejection never occurred. And this can be done regardless of the morphology for the right ventricle or the left, regardless of the morphology of the pressure wave. This is widely reported in the literature now. It requires only a pressure waveform in order to calculate your end systolic pressure and derive your Pmax. And you need a measurement of stroke volume, but it assumes a minimal and fixed V0, which, as I showed earlier, is not necessarily always true. Now, the last thing I'll touch on here, I only have a couple of minutes, is alternative ways of using single beat metrics when you have something like 3D echo to generate maximum and minimum volumes. This paper came out in 2001. One of the interesting things on this is it's showing what happens after some catheter-based interventions for aortic stenosis, mitral repair, or tricuspid repair. And what you see here is they have loops. They show an end systolic pressure volume relationship and an end diastolic pressure volume relationship, but they actually have no caval occlusion. There's no load variation. And even here, if you look, there's an end systolic pressure volume relationship. And if I take it out here, it comes up with a negative value. And this one comes up with an even negative value, which are not plotted. But the question is, how did they derive end systolic and end diastolic pressure volume relationships without any preload variation? And what they did is they applied these single beat models that were initially developed for the left ventricle. This one described by Senzaki and Chen and Cass was in 1996 and has been incorporated into analytic models you can find online. And this is one for the end diastolic pressure volume relationship that was reported in 2007. So it is possible to generate a great deal of information that you would normally derive from full loops by knowing just the pressure and the maximum and minimum volumes that you can measure with echo. These are a few studies that validate this for both the left and the right. I won't spend much time on these. This is the display you will find now from the commercially available device made by LACOM that is approved for use in humans. And this analytic module incorporates both multi-beat, when you can do caval occlusions, and single beat analyses. And this example, which is from the right ventricle, there's no caval occlusion or preload variation. So these numbers really don't make a whole lot of sense. And your primary analysis would be single beat metrics. It is possible to do these things now in real time at the bedside. These are two reports showing that you can generate ejection fraction, contractility, afterload, their ratio, You can estimate ejection fraction off of this and end diastolic volume. This can be done beat to beat in real time at the bedside. And here's the last little bit of wizardry I want to show you. This is a methodology that is actually able to generate pressure volume loops using only a pressure waveform. So it actually estimates the ventricular volume signal and from the pressure waveform, and this is shown in an example here. This is during an invasive CPET with continuous incremental workload with an right ventricular pressure. And this again is modeling using only a ventricular pressure, which can be applied beat to beat. And this is an example of the loops that are derived from this intervention. So I know I'm out of time, so we'll just go back to our initial true or false questions. Obviously, this is not just a laboratory research tool, so we'll say this is false. Acute variation is still required for producing the optimal signals for analysis. This is true, but I think it may change in the future. The same analytic techniques are always applicable to both the left and the right. I'll say false, but maybe this is a maybe. If we take the methods and adapt them for the fact that the RV pressure-volume relationship is dynamic and will change depending on the background conditions, this may actually be true. Loop morphology can be an important variable. This is true, and we've said both for differences between the ventricles, but also a change in relationship to pathology, for example, valve pathology. And full pressure volume loops are required for generation of meaningful information. I would say this is false, as we're beginning to see more and more of these single beat models that are presented in the literature. So with that, I will end up. I know I wasn't able to get through all of this. If anybody has any questions, or more importantly, if I said something that was completely stupid and wrong, let me know, send me an email. And I've been asked again to reinforce to check your email for the survey information. And with that, I will end. Thank you.
Thanks, Dr. Heerdt. One question from the group. Fantastic talk. What would you recommend as a resource as far as books or other types of maybe online resources for people that would like to learn about this in a little bit more
Yep.
detail at, at a slower pace?
The best that I know of is this. And I don't know if any of you use the Harvey simulator, which is an online textbook, which has the best examples for pressure volume analysis. And it also allows you to go in and manipulate pathology and different characteristics. This I've shown, this is from a study we did several years ago, actually validating its ability to produce meaningful loops, analysis of loops. So one of the best is the Harvey simulator. You can find it online. It might even be called pvloops.com. And I highly recommend this as a resource.
Yeah. All right. Well, thank you everybody for joining today. Dr. Heerdt, thank you so much for your time and your expertise. That was a fantastic talk. Just as an announcement for everybody, next week we'll be meeting on Friday, same time, and we'll be talking about transplant immunology. So quite a different topic from today, but that's the beauty of heart failure cardiology. So thanks everybody for joining, and I hope everybody has a great week.
Thank you. Bye-bye.
Thanks, Paul.